Yes. Yeah. Yes.
Hello. Yeah, good afternoon. Yeah, just joined, but I just wanted to know whether I'm audible or not. I was just checking.
Good afternoon, sir.
Hello. Yeah, good afternoon. I'm not able to hear sounds.
We can hear you. Yeah, we can hear you. Hello.
I'll just check it.
No, at the moment, no one is speaking, sir. So you can hear now, sir?
Yeah. Now I'm able to hear.
Okay.
Yeah, good afternoon.
Good afternoon, sir, and welcome.
Yeah. I don't know how this program, how it is working. So
sir, our lecturer will be presenting the case. She has also made a PowerPoint presentation.
Okay.
So she'll be sharing the screen. Okay. So as she reads out the case, you can also go through the slides.
Okay.
And so you can interrupt at point of time for any clarification and
No.
to ask.
What's the time limit now? 3 to 4 or 4? 5?
3 to 5. So means 1.5 hours as the case progresses.
No issues. Who are all joining? All the faculty and postgraduates?
Yes, yes, sir.
You are involving outside practitioners also, or only medical college?
Only medical college. The others also will be there as attendees.
Okay.
So for interaction, the link is open only for PG students and residents.
Okay. Madam has joined?
No, just a minute, sir.
Okay. Now, I just wanted to know how many PGs now you are having?
2 batches are there at the moment. So 7 each. So total 14.
14. So they are taking the final batch next year or December?
The 2020 batch is there and the 2021, but they joined in February 22.
Now,
And the resident who's presenting is the one who joined in 2020. She'll be answering next year.
so all PGs will be there, no? We can
Yes.
ask anybody. Or only.
Yeah, we leave it open, sir.
Okay, fine. No problem.
Hello.
Yeah. Hello.
Yeah,
Good
good
afternoon,
afternoon,
madam.
Dr.
Yeah.
Good afternoon, Dr. Rattigiri. How are you?
How are you? Yeah, fine, madam. Fine. How are you, ma'am?
I'm fine. Good.
Yeah.
Yeah. So, at the outset, I would like to thank you, sir, for accepting our invite. Yeah, let me just say a few things to my PGs who have joined in. Yeah, so we have Dr. Rattigiri today, okay, who's an eminent teacher. He's a postgraduate from AIMS, Delhi. And he's been an excellent teacher, currently working in KIMS Hubli. He has a lot of publications for national as well as international journals. He's also a nodal person on several IAP committees as well as for DIAP. So we are fortunate to have him here to use this opportunity to gain immense knowledge from him. So I hope you all PGs would really learn a lot from Sir today. Thank you, sir, once again for joining.
Thank you, madam. Thank you for your kind introduction.
So I will just hand over. So my PG, Dr. Vinetra, she is a final year PG. So she would be presenting the case and we could move ahead from there for discussion.
Okay. Thank you, madam. Thank you.
Yes, sir. Yes, sir.
Good afternoon, sir.
Yeah, good afternoon.
My name is Dr. Vinetra Rodriguez.
Okay.
Can I start presenting?
Yeah, before you start, I again thanks to Madam Vaishali Madam for giving this opportunity, and Goa IAP and Goa Medical College, all the staff members, especially Dr. Shilpa, Dr. Jagdish Bhatt sir, who are always there with us for all the exams. So really thank you. And here I just wanted to tell all the postgraduates, this together we can learn. It will be a learning exercise in the sense together we will approach. I don't know what case you are presenting, but we will try to learn how best we can approach as a general pediatrician. It's a day of subspecialty, super specialty, even in pediatrics. But still, general pediatrician plays a big role in approaching any child. So the whole concept here is how we need to approach a child whenever presented with various symptoms. We'll try to learn, we'll try to discuss things in that way. Okay. So
Yes,
if you don't mind, I can ask other postgraduates also if you can share, if you are not able to not able to answer or not able to get the flow, then others can share their knowledge. There is no hard and fast rule that you are the presenter and you need to tell all the answers. Not like that. All the postgraduates can put their inputs whenever we are having discussion in this. Okay, so there is no this thing. I am the first disclosure again. I say I will not be your examiners. Don't worry. So it is only a case approach how we can go, how best we can approach and come to a differential diagnosis without investigation. That's what our intention should be. Okay.
Okay, sir.
Okay. Thank
Okay, sir.
you. So you can start presentation.
Yes, sir. You can hear me?
Yeah, slide is visible.
The case we're presenting today is Halikama, 6-year-old female child, native of Karnataka, currently staying in Vasco, born of a third degree kindness marriage. History is given by the mother and is reliable. Child is right-handed. Child came with chief complaints of fever for 5 days, 10 days back, seizures for 1 day, 14 days back, altered sensorium for 6 days, 8 days back, and noticing.
Please close the smaller window.
Okay.
Fine.
And noticing inability to speak for 7 days. History of presenting illness. Patient was apparently all right prior to illness, following which child developed fever, moderate grade, intermittent in nature, which would subside with medication but recur within 4 to 6 hours, associated with chills and rigors. Fever lasted for 4 days, following which the child has been afebrile for the last 10 days. Child had abnormal movements described as twitching movements of angle of mouth towards the left with tonic-clonic movements of both upper limb and lower limb while child was asleep. The episode was associated with fever and terminated with an IV medication at a local PHC. Child was lethargic following the episode. 2 hours later, child had another similar episode lasting 5 minutes, which was again terminated with IV medication. Again, child was lethargic following the episode. Following admission, the child had 2 more episodes of similar semiology, the GTCS with impaired consciousness, on 2 consecutive days for which IV anti-epileptic drugs were started. Following that, no further seizures were noted following the 4th day of illness. The child was lethargic following the seizure, not responsive to oral commands or the surrounding environment. The activity of the child improved on day 6, where child was awake and looking around. Currently, child is awake and observes surroundings but does not follow oral commands. On day 2 of illness, the child was noted to have decreased movement of left upper limb and lower limb. Initially, child was unable to move the upper limb at all, and she was able to move the leg in bed, but not above the bed. She was unable to move the fingers or toes and was unable to roll over in bed or hold her head. Gradually, the weakness has improved. Currently, child can move the upper limb in bed, but not above the surface of the bed, and can move the lower limb above the surface of the bed. On day 6 of illness, child was noted to have no verbal output and not following or oral commands as well. This has remained the same throughout the hospital stay. Negative history, no history suggestive of any behavioral changes prior, no history of abnormal smells, no history of noticing drooping of eyelids or squint, no history of drooling of saliva, no history of ringing sensation in the ear, no history of change in voice, no history of thinning of muscles, no history of swaying, no history suggestive of involuntary movements, no history suggestive of tingling or numbness, no history of frequent falls, no history of swaying or abnormal eye movements, no history of any bowel bladder disturbances, no history of any trauma, no any history of nosy rashes, no history of headache or vomiting, no history of loose stools, no history suggestive of cough of chronic duration, breathlessness or cox contact, no history of COVID contact, no history of bleeding from any site, no history of ear discharge, no history of repeated blood transfusions, recurrent leg ulcers, no history of bony pains, noticing weight loss, no history of toxin consumption. So I'll go ahead.
Yeah, I just wanted to interrupt here. At this juncture, what do you think child probably
Yes, sir.
having? So what do you think?
Child-
Child has started with fever and then had convulsion
Yes, sir.
and into
Yes, sir.
alteration, sorry, and the examination, somehow they have noticed there is a weakness. So what
Yes.
do you think child probably having?
Sir, you're thinking of acute febrile encephalopathy the child has because of the fever, the seizures, and weakness which is following the seizures. Could be infective in origin.
Okay. So what are the common infective etiology which can present with acute febrile encephalopathy?
It can be viral agents like enterovirus, varicella, sir.
Varicella is so common?
No, sir. But
okay, which virus is common?
HSV, sir.
Very good. So HSV is one which can come very commonly. Second, any other infective etiology? Virus among that, HSV is the best one. Next.
Sir, enterovirus is one.
Okay, good. And depending on season, you can have different viruses they can present. So in your locality, which virus is common apart from these two, entero and the HSV? So it depends on locality where, and especially you said they have come from their native of Karnataka. Which part of Karnataka? because we are having certain viruses which are very prevalent in certain parts of Karnataka. Like if it is in North Karnataka, JE virus is very quite common, right? So which part of this Karnataka is
Right,
most important? That you need to ask. Okay, right.
So she's from Hubli actually.
So still this is a border area, though we are getting more cases from the Ballari and other area, JE cases. Here also we are getting if they are having their travel history. So there is a known entity. So you need to keep a possibility of GE also.
G. Yes, sir.
Okay, right.
Yes, sir.
Okay, that is another virus which can come. And now we are having the season of dengue. Can we
Yes, sir.
present with encephalopathy?
Yes, sir. Dengue also can present with encephalopathy.
Okay, other
Dengue.
vector-borne.
Others are malaria also.
No, before we go to other infection, let's finish other virus which are present like a encephalopathy features. Which other virus? Dengue, other vector-borne? Though it is not
Adenovirus, sir.
No. See, dengue and chikungunya, they can present with neurological manifestations. Huh? So you need to always keep, though dengue is so common, but remember, even chikungunya can present with neurological manifestations. Okay? So depending on season, depending on the area from where they are coming, you need to keep the top priority of these viruses, which are very common. Okay?
Yes.
Right. So one is infection. In that virus you have completed. Next, any other infection which can present with acute febrile encephalopathy?
Malaria, sir.
Okay, parasitic cerebral malaria. Very good. So in your area it is so common, so you can get cerebral malaria. Is it common now or it has been eradicated from your area?
No, it is still present, sir. Malaria.
Yeah, cerebral malaria. Second. Third, very common. Any acute febrile encephalopathy comes, we need to keep three possibilities always first. So one virus we have covered, second parasitic you have covered. One more, very important.
Tuberculosis, sir.
No, tuberculosis, no. Acute. You are saying acute. Usually tuberculosis will be little more chronic. Huh? So acute, which one you want to consider as acute febrile encephalopathy?
Meningococcal, sir.
Pyogenic meningitis. There are different organisms which can present. So it is always considered pyogenic meningitis as a third cause. Okay. So depending on again the way child presents, what is the age group, based on that you can find out what organisms are common. Okay. Now 6-year-old, which organism you consider as common for pyogenic meningitis? So, like pneumonia, so you have
streptococcus.
Streptococcus pneumonia. So they will have common presentation, common organism. Okay. So that can present, and you can have, if it is a younger child, say first 2 months of life, usually gram-negative organism you have to consider. Okay. Right. If child is presenting with some, what you have now said, meningococcal, how they present?
So there'll be a petechial rash on the body, along with fever and seizures.
What is most important? Okay, any child present with fever, petechial, you have so many differential diagnoses. But to say it is meningococcal, what is most important?
History of travel, sir.
Okay.
And cough, coryza, sir.
Okay. More important, I will say it is surely likely chance of meningococcal is more common. If I got that history, what is that? See, it comes in epidemic, no? It comes in epidemic. So many people at the time, sudden onset, deteriorating very fast, having rash, fever and rash, deteriorating very fast in epidemic. Say some schools are affected, some locality is affected. Definitely you need to consider the possibility of meningococcal disease. Okay?
Yes, sir.
Okay, so these are common three indication or three causes for acute febrile encephalopathy. Can you consider some other history? Because you have taken so many negative history, but there are some more important which you have forgotten. What other causes can produce acute febrile encephalopathy apart from these three causes? Any other thing you can consider?
So ADM, acute demyelinating encephalopathy.
Okay, again, it is a part of viral. Okay, next. Other than these three causes, anything else you want to consider? What are the other causes?
Other than
Yeah, other causes of acute febrile encephalopathy, though they are not much, but these should be considered as three, and then subsequently, based on history, you can consider other causes. Like, I'll give a clue. Now, if a child has, yeah, tell me.
So hypercoagulable states.
How hypercoagulable present?
So like
Common.
sickle cell, sir.
How they will present? Why they will present sickle cell? Is it so common in your area?
No, sir.
Okay, I will tell now. The mother says that just prior to onset of fever, child had a blood stool. Stool as contains the blood, and then subsequently child has developed the fever. And now after third day, he developed a convulsion into ultrasound. So what do you think? Probably child is having. There is acute onset of diarrhea.
Hemolytic uremic syndrome.
Common.
Decent.
Yeah, common. So I request others can put their words in the message box also, their differential diagnosis. Okay, one of the participant has mentioned correctly, Shigella or Salmonella. These two are very common. No? So they can present with blood in the stool, and later they can manifest as encephalopathy. So that you need to consider. Okay, so that history you have to take when you are taking, whenever you have a history, acute onset of fever, convulsion, altered sensorial. Should always keep this in mind. Is there any history of bleeding? Okay,
okay, sir.
So that is one. Any other possibility you want to consider? Acute febrile encephalopathy. You said petechiae fever, then altered sensorial convulsion. Any other bleeding manifestations? Any other disorder which can present with this? And it's a short history, very short history. Child is sick looking. Malignancy. Any malignancy can also sometimes present with the acute febrile encephalopathy. So you need to take that history, bleeding manifestations history. Okay. So there are other manifestations. There are other conditions which can come with the acute febrile encephalopathy in these days. Earlier, it was located to particular areas. Now we have. So one of the participants has mentioned one of the cause is. So there is a rainy season. Diarrhea episodes are going on. So what else you can consider?
Rickettsial, sir.
Yeah, very good. Rickettsia in particular areas you can consider, but I said it is rainy season. Post rainy season, you can have this one. What is that condition?
Leptospirosis.
Leptospiral. Okay. So these are based on your history, you can consider as cause of acute febrile encephalopathy. Okay. So all these history should come in your presentation. Okay. Right. There is one question. You said there is weakness in the upper and lower limb. I just wanted to know this weakness, how long it lasted. Is it for a long time or it is for a short time?
So it's 6 days only. Since 6 days.
So what do you think this weakness? Is it because of illness or is it like post-convulsion, what we call as post-ictal phenomena?
So it could be because of organic cause, not because of the convulsion per se. As in, if it's convulsion, it would have
why not it is post-ictal phenomena?
So it would have improved by now, as in resolved by now.
How long it will take? Usually, post-ictal phenomena, how long it will
Within
last?
24 hours, sir.
Generally, it will be by 24 hours, but sometimes it may go up to 7 days. So very, very rare it is. But by and large, by 24 hours, it should resolve. Should always consider that as a post-ictal phenomenon. Otherwise, we have to consider first as organic insult. Okay.
Yes.
Right. Okay, proceed.
Treatment history. Child was admitted as case of acute febrile encephalopathy. Phenytoin and levetiracetam was started in view of seizures, and phenytoin was gradually tapered and omitted. Currently, child is on levetiracetam. As child had post-sensorium, she was ventilated for 5 days and later extubated. Currently, child is on room air. As child had hypertension and bradycardia at the time of admission, considering cerebral edema, 3% NaCl and mannitol was started, and later it was gradually tapered and omitted. Acyclovir, ceftriaxone, and amikacin were started on a suspicion of viral encephalitis. Ceftriaxone was later changed to meropenem as fever was persisting, and it was omitted after 10 days as cultures were sterile and fever had also touched baseline. In view of the weakness, aspirin and low molecular weight was started. Low molecular heparin was started. Past history, the child at the
just
age
one
of 4
minute.
years had an episode.
Can you go back to the
Yes, sir.
previous slide? Yeah. Now you said, what is your protocol in your hospital whenever a child comes with convulsion? Which is the first anti-convulsant you would like to start?
We usually start phenytoin, sir.
If child is having shock, because the presentation is like a shock child presented. So would you like to give first phenytoin, or you want to have other alternative if child is having shock? So whenever child is in shock, try to avoid phenytoin. It will further induce the hypotension and shock. So you should avoid and use other alternative anticonvulsant. So safe in shock is nowadays levetiracetam. So you can use for that one. Okay.
So I can proceed.
Yeah.
Past history. Child at the age of 4 years had an episode of tonic-clonic movements of left upper limb with fever, which was around 103 and 204. The left focal seizure would occur around 2 to 3 times a day, lasting for 1 to 2 minutes. The episode was associated with weakness of the left upper limb. The weakness of the limb had improved in 7 days, and the abnormal movements also stopped in 7 days. During this period, the child was at home and did not receive any medical attention.
So how it is
Antenatal history
related to your now present history? Is it significant?
Yes, sir. It could be like a indicator of recurrence weakness.
Okay, very good.
Like
so
the prior
child,
episode.
child
like
is
the
having
prior-
already having
Yes.
one episode of weakness,
Yes, sir.
and for which medical attention was not there. But now second episode with the fever, they have come back. So what do you think probably it is? Is it, can you call this as a recurrent
It's like a recurrent stroke, sir.
stroke? Okay. So what are the common causes? If a child, say 6-year-old, having recurrent episodes of weakness, well, that time also it was right side only?
No, sir. That time, as in the first time, sir.
First time?
The first time is a left focal seizure. Yes.
So second time it is right side.
No, the second time, sir, it is she's giving bilateral history.
Bilateral. Okay.
Yeah.
Both upper limb and lower limbs
The
were
limbs.
having.
Yes,
Okay.
sir.
Okay. So can you call this as recurrent stroke? When do you call stroke?
When there's a residual paralysis,
Residual paralysis. What is the definition of stroke?
it is
Yeah. What are
sir,
the character when to say child is having stroke?
whether a child has weakness of an affected part.
Weakness only, or any other components also you need to include. Onset, duration, is there any significance when you are defining stroke?
Usually because of a loss of blood flow to a part of a brain, damaging the brain, like causing some damage to the brain tissue.
Okay, sudden
That
onset.
that causes some residual neurological damage.
Okay, right. So do you call this now, these two events, considering these two as, you can take it as recurrent? Or just a coincidence? What is your first possibility? You want to say it is a recurrent, second episode, or it is not part of this one? This is a fresh episode. It is not related to the previous disease, whatever it is the cause or the first episode of weakness. How do I know that the first episode itself is progressing and now child has presented for the second time? What history can tell us that probably the previous one is significant to take into consideration now the second episode? What history would have helped us? What are the other history you need to take? Progression. Child is progressing means what other history you need to consider? Other postgraduates can add your this thing. So what else you can consider? If it is independent, no problem. You want to consider this as a part of that one, then there might be some interesting history you need to, or you would like to ask.
Sir,
Yeah, tell me.
sir, I'm unable to get the audio of the.
Acha, you are not able to hear my voice.
Yeah.
Okay, now able to hear? Still no.
No, sir. Hello.
Hello, are you able to hear my voice? Hello.
Sir, can I log in from another phone?
Yeah, you can go, no problem. Now, able to hear or not? Is it problem of yours or mine?
Sir, you can hear me?
Now, I am able to hear your voice.
Okay. Sir, I'll present the past history again.
Yeah, it is there already. We know that one. My question is, this
Yes, sir.
past is to whatever the episode has occurred, whether that is a part of this second episode or it is independent. Are you able to?
Sir,
No, you are not able to hear my voice.
sir, yeah, I can hear. So
Yeah.
can you repeat the question?
Hello.
Hello, you can hear me, sir?
Yeah. I'm able to hear.
Sir, can you repeat the question?
Question is, the first episode occurred 3 years or 4 at what is that? 4-year-old. When he was 4-year-old, first episode has happened.
Okay.
Okay.
Yes, sir.
Okay. Now the second episode also now at 6 years. Now both these episodes are part of one disease or different.
So they seem to be part of one disease only.
What history is pinpointing you to say that there is one disease which is progressing? What history is there? That's what
Sir,
I'm asking.
So initially there was also involvement of, there was some seizure followed by weakness, and that was also associated with fever.
Okay.
And the second episode also there's fever. It's a seizure which is again followed by weakness.
Okay. But what happened in between these two episodes? There is a 2 years gap. So is there any clue that there is a progression of the disease?
Initially, so it was just one limb involvement. Now it is like all full, as in the left upper limb and lower limb, there's weakness.
Okay. Then why you want to say it is a different entity only? This is a new infective lesion. That time probably child might be having febrile, simple febrile convulsion. Now this is a different entity. Now child might be having encephalopathy. Is it correct? Or still you have some clue to say that probably it is other disease which is progressing.
So could be some latent virus, sir.
Latent, which latent virus? Which can go on for this long 2 years? Okay, you tell me now what disease you want to consider. Now 2 episodes have occurred. So probably one disease which is progressing. What you want to consider? Which disease? Will come in the other way. Which disease you are having in your mind to say that that is progressing now?
HSV.
HSV, can it present, sir? Repeatedly. And where it will be presenting? Only in immunocompromised children can present. But first episode doesn't look like HSV. Yes or no?
Yes, sir. Yes, sir. Varicella, sir.
Varicella, again, within 2 years, second episode, unlikely.
Some metabolic disorder, sir.
Okay, good. What metabolic disorders you would like to consider, which can have a recurrence later?
So the mitochondrial disorders.
Straight mitochondrial disorders. Why you want to consider mitochondrial disorder?
Because it's a recurrent episode, sir.
Okay. But what happened in between which you have not taken? That's the reason I asked, what are the clues? If you want to consider metabolic disorder as an underlying problem, what history is there in that 2 years gap, which is very important for us? That can give some clue that probably it is underlying metabolic disorder or something else. So what history you would like to ask during that 2 year period?
So the child was normal between the 2 years.
Okay. Only total absolutely normal, gaining weight normally, no infection in between, or no episodes of other problems which can manifest. It was not there, sure.
Yes, sir. Yes.
Then it is unlike generally in metabolic disorders, we get one or the other way. Okay, one or the other symptoms which will be keep on coming in between because of certain precipitants. Okay. If that is not there, then the likely chance is lesser. Okay. So you need to ask that history. Is there any in between episodes and what happens? Is there any extra manifestations of this? Right?
Yes,
okay. Okay. Thank you. We can proceed now. Your slide is not working?
Yes, I'm just trying to get that.
Okay. Okay, for other postgraduates, till she shows that next slide. So whenever you are taking the CNS history, if child is presenting like this fever, ultrasensorial convulsion, so all you need to take is like your examination. So you will not miss anything. Like you can start with whatever presenting illness, describe those illness correctly, and start like a CNS examination, like higher mental function, all the details in the history, then cranial nerves, then the motor system involvement, then sensory system. So you can get all the information before you go for the final examination. Examination in CNS is only to confirm. So in the history only, you will be able to make a correct diagnosis. Where is the problem? Provided if you are going in that
much.
Okay. You are not able to load, Vinitra? Yeah. Yeah, we are able to see your slide.
Yes, continue, doctor.
Yeah. Dr. Vinitra? Yeah, who is there? The DIP host?
Short.
Yeah.
Yes, doctor, what's the issue?
Yeah, no. From the other side, those guys were not able to speak. I'm not able to hear their voice. Is there any problem?
I'm not able to hear. Nobody is speaking actually.
So other side is okay, or there is some problem?
So there must be Vinetra's connection must be an issue. She'll join
Yeah,
back soon.
Dr.
Okay.
Vinetra's problem. Because
Okay.
we are able to listen everything.
Okay.
Dr. Vinetra, kindly unmute yourself.
Hello, sir, you can hear me?
Yeah, we are able to hear, but
Dr. Vinetra, kindly mute on one device. You have two devices, I think.
So you can hear?
yeah, we are able to hear.
Birth and postnatal history. Baby was born at 7 months
Your
by
screen share has been stopped.
so you can see.
Yeah. Okay. Fine.
Okay. The baby was born at a 7th month by spontaneous vaginal delivery. Birth weight was around 1.5 kg. Cried at birth. Was admitted in NICU in view of low birth weight and prematurity. There was no history suggestive of hypoglycemia or seizures during the neonatal period. The child received IV medications. Details are not known. Initially, child was on tube feeds during the first week and was made spoon feeds by the third week. The baby was discharged after around 3 to 4 weeks on spoon feeds, and breast feed was started around the third month. Developmental history: the child was developmentally normal child. Immunization: child was immunized for age. It received a last immunization at 5 years of age. Dietary history: total caloric intake is 1,380 kilocalories per day. Required is 1,500. There's a deficit of 120 kilocalories. Total protein intake is 25 grams per day and required is 26 grams per day. Family history, there is a third degree consanguineous marriage. There's no history of seizures in other family members, no history of developmental delay, no history of cross contact, and no history of COVID contact among other family members. So I'll
Okay.
head on to the.
Yeah. Just summarize what is this thing.
To summarize, sir, this is a 6-year-old child who has presented to us with fever, seizures, altered sensorium, and decreased verbal output. Otherwise, the child has no significant this has significant birth history where she was born at 7 months of age, required NICU care. Otherwise, immunized for age, developmentally normal child.
So only thing we missed is verbal output. We didn't discuss much about the verbal output. What do you
Yes,
think child might be having?
Child is actually not, there's no verbal output and she's not even following oral commands. So it looks like aphasia.
Aphasia. So where is the problem you want to consider?
Aphasia would be, it will be in the cortical involvement, sir, in the dominant lobe.
Okay, he is a right-handed person.
Left, yeah, so the left.
Left. So which area you would like to, in the cortical, which area that is most important?
Around the distribution of the middle cerebral artery, sir.
No, what is that area
Broca's,
called?
Broca's area, sir. Broca's area.
Yeah, Broca's area. Okay. Specific, is there any, how we can now, there's a big area. Now you want to see which part of that area is affected. We have both sensory, motor and mixed part. Is it not?
Yes.
So which area you would like, to, based on your history, which one you will consider, where is the problem?
So actually,
You are not able to get the history from the parents?
Actually, it's looking like more like a right, actually, the distribution of middle cerebral artery.
Why?
There's a left-sided weakness with seizures and aphasia.
Aphasia. So it is right. But you said he is a right-handed person.
Yes.
So how you can correlate this? But what is the explanation? Simple.
So that probably the dominant, as in there's also a left-sided involvement.
Yeah. Remember that one. Even in right-handed person, it is always left-sided. Main dominance. Okay.
Yes, sir.
Right. Okay. Now proceed with the examination.
So child is lying in bed with a
Next slide. Next.
Yeah. Child is lying in bed with a nasopharyngeal tube in situ and right femoral line. The temperature is 98.6 degrees Fahrenheit. Pulse rate is 102 beats per minute, measured in the right radial artery, regular. BP is 102/64 millimeters of mercury, checked on the right arm, which is within the 50th and 90th centiles for age. RR is 24 beats per minute, and peripheral pulses are well filled.
Okay, but you have not mentioned about his conscious state. You says lying bed, but what is the status? That is most important when you are describing the general physical examination. Is he in altered sensorium? Is he conscious?
So child
what happens?
So child is conscious, sir.
But you are not mentioning that. That is the most important. Yes or no?
Yes, sir.
Okay. So if child is in altered sensorium, your TDs again you have to consider differently. Now, if it is improved and conscious state is there, then you have to think of other conditions.
Yes, sir. Yes, sir. Anthropometry wise, sir, the weight of the child is 20 kgs, length is 122 centimeters, head circumference is 41 centimeters, which is less than 3 standard deviation. BMI is 13.4, which is between 0 to -2 standard deviations, which is normal.
Okay, what is your impression at the end of anthropometry? What do you think?
So the child has microcephaly.
Yes, very good. Microcephaly. So is it primary microcephaly or a secondary microcephaly?
Yes. So it could be a primary microcephaly.
Why you want to say it is primary microcephaly? How do you differentiate primary and secondary microcephaly?
So in primary microcephaly, there will be this could be because genetic causes. It
Clinically, how will you differentiate primary microcephaly versus secondary microcephaly? Other postgraduates? So you can make it out primary or secondary. On what basis? Any other postgraduates? I got some messages, but still more important. One is saying scalloping, other primary disorder. Primary is a disorder of brain function. Frontal sloping in primary, very important. See, this is very important one. Recession of frontal. So that is the most important criteria. Where do you get that one? In primary or secondary? In primary you will get. Okay. Right.
Primary,
so
sir. Primary,
yeah,
sir.
right. And one more point I would like to stress here, the definition of your microcephaly. When you will consider microcephaly?
Less than 3 standard deviations.
If it is less than -2 standard deviation, we will not call it as microcephaly. Only -3 standard deviation will take. So we have two, one neurologist, other is genetic specialist. So genetic specialist will consider even -2 standard deviation is also as microcephaly. Why? Both will be taken, -2 standard deviation and -3 standard. But both have some significance. What is that? Any idea? No?
No, sir.
I said I have given you a clue, genetic and on neuro. Others? Okay. We Indians fall in brachycephaly range. Okay. That is not the answer. So any other? Okay. Primarily, when you are saying it is -3 standard deviation, more likely it is of the defect of the brain, developing brain. Okay. So usually you get your all chromosomal anomalies and other things -2. So -3 standard deviation. -2 standard deviation is a part of other than your chromosomal anomalies. Okay, so that's how genetics and the neurologist people will be differentiating. But for all practical purpose, you can define microcephaly taking both into consideration, -2 standard as well as -3 standard deviation. Okay. Now it appears in this child it is severely microcephalic, just 41 centimeter at 6 years of age. Okay. What about has weight and length? That is also decreased, no?
BMI, sir,
yeah, 13.4. So that is minus
0 to
-2. Okay. But normal BMI at 6 years, how much it is?
Sir, around 13, sir.
I think 14 to 16 is the normal BMI. Normal. So it is also on lower side. So it is, there is definite malnourishment is there. Plus there is a microcephaly. Both are significant for us. Okay.
Okay,
Proceed, please.
Head to toe examination. Head appears small. Eyes, there's pallor present, no icterus. Ear, no discharge present. No facial dysmorphism. Neck, no neck swellings lymphadenopathy, chest and abdomen, post-inflammatory marks are present, limbs, no cyanosis, no clubbing, no edema, no neurocutaneous markers, spine appears normal, and there are no contractions in the child.
So what neurocutaneous marker would like to see in this child?
For any cafe au lait spots or neurofibromatosis,
Okay. Any other?
Ashleigh macules,
Hmm.
for tuberous sclerosis.
Okay. Any other? So there is a big list
He
of
mentioned-
neurocutaneous markers
Yes.
with some relevance for each disease. So
So-
considering this in your child,
Hemangiomas,
very important.
hemangiomas,
stain.
port wine stain
Yes.
in
very-
Sturt Weber.
Any other eye related?
Ataxia telangiectasia.
Yeah, ataxia. Okay, so you need to consider this one. Now, I just wanted to tell for all postgraduates here, like a neurocutaneous markers, you need to take one more significant examination point, that is vitamin deficiency signs. Okay, in all neurologic cases, you should always examine for these vitamin deficiency signs. Did you look for that one? Because I'm not able to see in your slide.
Yes, sir, we had looked for signs of vitamin deficiency.
Why it is important?
So vitamin B12 deficiency in person neurological.
Vitamin B12 present. How it will present? What are the manifestations? B12.
They will present with weakness, tingling, numbness,
Any other?
developmental delay also if it's presents early on.
Remember, post-COVID days, vitamin B12 can manifest with any manifestations of neurology. Okay, so you need to consider that one significantly in this post-COVID era. That is one. B12. Any other vitamins which can manifest with neurological manifestation?
B6 deficiency,
Okay.
paradox. It may present
Okay.
with seizures.
Okay, good. Any other? In the examination, you will have these findings. What else? So your friends are adding. What else? B1, B2, B6, even B5 can present antithonic acid. Huh? B6 deficiency. So you need to look for all these signs. Huh? Then vitamin E, very important. They can also present. What is the clinical manifestation of vitamin E deficiency?
No, sir.
Yeah.
Can you
Vitamin-
repeat the question?
Yeah, vitamin E deficiency signs. How do they manifest?
Decreased sensation in legs.
Your postgraduate has, one of your friend has added.
Doctor,
can-
I request there's some kind of echo. I request all to just do not log in from two devices at a time. There are lots of echo actually.
Yeah, vitamin E deficiency. So your friends have added. Huh? They can present with ataxia. In newborn period, initial manifestation, they can present like a hemolytic anemia. Okay, so these are clues you need to take into consideration. And make sure, like a neurocutaneous markers, look for vitamin deficiency signs, especially in neurological examination. Neuro case.
Yes, sir.
Next.
CNS, higher functions. Child is conscious. Orientation, memory, and intelligence could not be assessed. Speech, she has no word output and she doesn't follow oral commands. So she's having global aphasia. The cranial nerve examination, second cranial nerve, light reflex is present. Third, fourth, and sixth, there's no ptosis, no squint, doll's eye movement is present, and direct and consensual light reflex is present. Fifth, cranial nerve, corneal and conjunctival reflex is present. Seventh, there's no deviation of angle of mouth, no drooling of saliva. Ninth and 10th, gag reflex was absent. 11th, what is this? 12th, there are no tongue fasciculations. Motor system, the bulk of the muscles appears flabby. The circumference of the limbs are equal and comparable on both sides. The tone is decreased in all four limbs. The power in the upper limb, at the shoulder on the right, shoulder, elbow, and wrist, it is all 3/5 on the right. On the left hand side, the shoulder, it is 1/5, elbow, it is 2/5, and wrist, it is 2/5. Lower limb, it is the hip, it is a knee and ankle of the right lower limb, it is all more than 3/5. Whereas on the left hand side, at the hip, it is 2/5, knee, it is 3/5, and ankle, it is 3/5. Power of the small muscles of the hand could not be assessed. Reflexes, abdominal were absent. Plantars were downgoing on both sides, superficial to superficial. And under deep reflexes, biceps, all the reflexes were actually depressed. Sensory, so the patient withdraws to painful stimuli. Cerebellar, there's no titubation noticed, no nystagmus observed. No signs of meningeal irritation, and cranium and spinal are normal.
Go back to previous slide.
Yes, sir.
Previous.
Yes, sir.
Yeah, the previous one. Is there any cranial nerve also? No, no. All cranial nerves are normal. Examined.
Yes, sir. But only thing, the gag reflex we could not get. Otherwise,
so appears all cranial nerves are normal. Yes or no? Hello. Hello. Dr. Vinitra. Again disconnected. Yeah, other postgraduates. So if hello. Okay. So if cranial nerves are normal and the higher mental function is little more in adolescence, or I think this child is having consciousness, but no other this thing except the speech part which is affected. As per the examination findings, it appears it is a basic child. Agreed. But motor system examination showed the left side is more weak than the right side. Right side appears normal. So what do you think probably child is having right now at this thing? Hello.
Hello, sir.
Yeah. Tell me.
Thing is that the thing got cut. Can you add me as the panelist?
I think from DIP, they have to make that one. DIP person should do that. So is there, whoever is in charge of this one. Okay, anyway, now till she joins, So what are your other differential diagnosis you will consider in this child? Looking at the CNS examination. So there is a weakness on the left side more, and rest of there is in the higher mental function there is a global aphasia, and cranial loss appears normal, and the motor examination revealed there is a weakness more on the left side as compared to right, but definitely more on the left side. And the other sensory system appears normal, but I am not aware of whether she has tested the cortical sensations, which are very important, the all 5 signs. So can you enumerate all 5 signs of cortical sensation? Other postgraduates can put up your this thing on the chat box. So what are the other cortical sensations you need to test? Okay. All 5. You need to mention all 5. So I got only 2-point discrimination and this thing. Okay. So I will just enumerate all 5. You have to test all these 5. The first one is tactile localization. Second one is 2-point discrimination. Third one is tactile extinction. I'll come to that one. Then fourth is stereognosis. And fifth one is graphesthesia. Okay. So these are the 5 cortical signs you need to test. So tactile localization, you all know how to test that one, simple. Then 2-point discrimination, you all know, but only thing, where are the physiological areas you need to remember, that is tip of fingers. And tactile extinction, very important one, which can differentiate which is affected part, which is not affected part. When you put simultaneously on one particular area on both sides, equal side, right thigh and left thigh, on equal point, if you put a present, the patient is able to appreciate on normal side. On the abnormal side, not able to appreciate. So that is what is tactile extinction. And then you have a stereognosis, which you all know, giving something and making it to identify. And graphesthesia, graphesthesia is just draw something and able to identify that one. Okay. So this is how you can test the cortical sensation. I think, I don't know whether she has tested or not. Probably, even if she has tested, nothing is there grossly, because it's a 6-year-old child. Difficult to me call that cortical sensation properly. Okay. So now, with all that, I think she has joined or not. Dr. Vinitra, other postgraduate, anybody who is supporting her can. She is not able to join?
Yes, sir.
No, she is able to join or not able to join?
Sir, I'm not able to join.
Okay. So what we should do now? Whether
Sir, I can present from another phone.
yeah, you can present, no problem.
Hello?
Yeah. Yeah, share your slides. Yeah.
Such slides I'm unable to share right now.
Okay, no problem. You can. So now what do you think? So other systems are normal?
Yes, sir. Other systems are normal. RS air entry is equal on both sides.
Okay.
Vesicular breath sounds are heard, no added sounds. CVS S1, S2 heard, no murmur. PA is soft, no distension. Bowel sounds are present. So, sir, diagnosis which we have given is that microcephaly with febrile encephalopathy with global aphasia with left hemiparesis with status epilepticus, most likely due to a cortical thrombotic stroke, which could be query meningoencephalitis, query metabolic, query hypocoagulability state, and query vasculitis, most probably involving the right and left MCA territory.
Okay, it's a big one. So you now start with showing the first one, right? So anatomically, what are the areas involved in this cell? Then
So
we'll go for, yeah.
So anatomically, it looks like the right MCA is involved, middle cerebral artery.
No, you should mention what are they. What are they? There is a left-sided hemiparesis or hemiplegia.
Sir, left-sided hemiparesis, sir, as in left and right, but left is more than the right, sir.
But right side is also having weakness. No, as per this thing, because you said it is power is more than 3. It has been mentioned in our slide. So likely that there is no weakness on the right side.
Yes, sir.
Okay, it is more on the left side. So it is a left-sided. Sure or not?
Yes, sir. Yes, sir.
Okay, so it is a left-sided hemiparesis. Then, is there any cranial nerve? So there is no cranial nerve involvement. Is it not? So, but there is a global aphasia.
Global aphasia.
Yeah. So left-sided hemiparesis with global aphasia. And any other this thing you have noticed? And you have noticed there is a microcephaly.
Microcephaly.
Okay. So here, considering all these, no cranial nerve involved, there is a history of convulsion. There is a hemiparesis on the left side. So what do you think? Which area? Cortical, subcortical, or internal capsule? Where is the problem? Or is it in the baseline of the heart? Sorry, brain.
Sir, cortical.
Why you want to say it is cortical involvement? Quick, fast, because we are running short of time.
Sir, cortical because of the limb involvement. It's not like a dense hemiplegia. It's a weakness only is there, and there is aphasia. Aphasia is more of a cortical involvement.
Okay, definitely.
And seizures, sir.
Okay. But when child presented in the first day, all 4 limbs you said there was a weakness.
Yes, sir.
Yes, sir. So at that moment,
Sir, presentation weakness is on the left hand side, sir.
Presentation also only left side.
As in the weakness is only left sided. Seizures was involving all 4 limbs, sir.
Okay, weakness is only on the left side. Was it
yes, sir.
Total plegia on that day, or it was paresis on day 1 itself?
So on the first day, she could not move, as in the day, on the second day itself, she could not move the upper limb at all.
Okay.
Lower limb, she could move in bed.
Okay.
But not against gravity.
Okay. Why don't you consider the dense hemiplegia during that time? Did you consider that? Day one.
On day 1, so
yeah.
But lower limb was better, sir. Dense hemiplegia would involve upper limb and lower limb both equally, sir.
Yeah, very good. So this is a point you would like to know. Now, obviously, there is aphasia, there is a convulsion. You will consider possibility of cortical involvement. But knowing the other parts involvement is also most important. Okay. If there is a dense hemiplegia, you would have considered even the whatever the pathology would have involved even internal capsule also. Now it is not there. So it is basically involved only cortical area. Okay. Right? Okay. Yes. Now these are there. Now what is the anatomy? You said all these 3 parts are there. Then what is the pathology involved in this? That is the second part we need to cover. What is the pathology? So is it, you said there is a circulation stoppage, but what is that? Is it emboli? Is it thrombosis? Is it hemorrhage?
Sir, looks more like a thrombosis, sir.
More like an emboli.
No, thrombosis, sir. Thrombotic.
Why? What made you to think that it is thrombosis and not emboli?
Sir,
I will say it is emboli because child is improving so fast.
Sir, embolus would have resolved immediately. Also.
Immediately without your treatment.
Yes, sir.
How fast it will resolve?
Usually within 24 hours, sir.
No, without treatment. With involvement or with intervention, they might. Okay. So any other reason why you would like to consider thrombosis and not the emboli?
So the weakness has taken quite a while to improve also. Like initially it was hemiplegia, as in the upper limb could not move at all. But currently she can move, like she has can move the upper limb in the bed. Whereas the lower limb, again, same thing. Initially, she could only move with the bell, but now against gravity. So some improvement is there. Secondly, it was like a sudden onset also in onset.
Yeah. So sudden onset, but slow recovery, likely there is a thrombosis. Sudden onset, but fast recovery, would like to consider emboli. Hemorrhage, how it will present?
So hemorrhage would have a sudden onset and would deteriorate from there. There would be no recovery as such.
Okay. What other symptoms will suggest probably it was hemorrhage? Clinically.
Clinically, altered sensorium would
more important. One more important.
Shock would be there. Hypertension.
More.
In the
Usually you have a headache and vomiting. That's a typical history we'll get in case of hemorrhage. So that history will be there and further worsening will be there. That's how it can depend. So that is the pathology. Now the third one will be etiology, right? So what is the etiology you would like to consider in this chart?
So an encephalitis.
Etiology means it is always the cause for the problem. So now we having thrombosis, you said, which disease per se can produce or etiology can produce thrombosis in this child? 6-year-old child. So one infected. Okay. In the infective, which one you'd like to consider first?
Viral, sir.
Viral. Which virus you said?
HSV, sir.
HSV, will it involve the, which area is very commonly involved? Which area? We have so many parts in the brain. So every virus has some predilection. So HSV is very interested in certain part. What is that?
Temporal, sir.
Temporoparietal region. Okay, temporoparietal region. Very commonly it involves. So are there any signs suggestive of involvement of temporal sign other than your aphasia, which is more of parieto-occipital? Okay. So here it is temporal. Any signs or symptoms you had suggestive of temporal involvement?
Only the seizures, sir.
Yeah, seizures. What type of seizures you will get in temporal involvement? So each of these will give us a clue whether there is a temporal involvement or
not. Sir, focal seizures, sir.
Very good. Very good. Focal seizures. Good. Okay. So now in this child, it is not focal, it was generalized. Okay. And more of aphasia rather than the other signs suggestive of temporal involvement. Okay. So still you would like to consider HSV or some other virus you would like to consider? Yes or no? We'll go first.
Yes, sir.
So still possibility of HSV you need to consider in our setup. Okay. Right. So if there is a JE, since he is from North Karnataka, so if there is a JE, which part of the brain is usually involved?
So thalamus.
Yeah, very good. Thalamus is the site where it will be involved in JE encephalitis. So they present with impact in the bilateral thalamic region. Very prominent sign in MRI. That will give us a diagnostic evidence. Okay, right. So one is viral encephalitis, probably HSV. Second, any other possibility you would like to consider? Or only one you want to stick? Only HSV.
So any hypercoagulable state, sir,
Why you want hypercoagulable state?
because of the thrombosis. So
Thrombosis. What hypercoagulables are common in pediatric age group?
um,
What are the
can be a
hypercoagulables?
second.
Yeah.
So some the 5 leader mutation, protein C, protein S.
How common it
Then
is? All postgraduates are very much interested in all these three: protein C, protein S, antithrombin T. Huh? How common it is?
it
Which
could be
is very
secondary
common. Yeah.
polycythemia also is seen in secondary to some heart disease.
Yeah, polycythemia history is not there in your child,
Okay.
and you don't have any congenital heart disease also in the history. Okay, so these two are unlikely cause for your problem in your child, right?
Yes.
Okay. Now my question is, you said hypercoagulable, but all these are how common they are. Antithrombin C, protein C, protein S, and antithrombin C. They are definitely there, but they are not so common. What is more common than these?
Yeah, dehydration, sir.
Dehydration state. So that is also nowadays good pediatricians. Everyone is giving IV fluids nicely. So dehydration part is also taken. What else? Very common in Indian setups. It will be presenting like a thrombosis.
Iron deficiency, sir.
Yeah, very good. Should always keep that in your mind. Though there are not much studies to prove that it is so common, but in our setup, iron deficiency anemia causing hyper or thrombocytosis to the extent of more than 8 lakhs. There is a high chance of thrombosis in these children. Okay, so that is another possibility you need to keep always, right? Okay. Any other hypercoagulable state? I will rather keep it down. Before that, after infective, any other cause you would like to consider?
Metabolic, sir.
Metabolic, good. Why you would like to con? Which metabolic you want to consider?
Metabolic, sir, mitochondrial disorders.
So any mitochondrial disorders, how do they present usually?
They will
All these metabolic disorders, they might be asymptomatic. One event can precipitate and they will suddenly deteriorate, right? So that typical history will be there. Like IEM, they will also have these features. Okay. Now, to say it is mitochondrial, what history or what sign is there in your child?
So prior to this, when she had got a fever, that time she had this seizure with some weakness in that hand 2 years back.
Okay. But that can be there in other condition also. Why you want to consider typically as mitochondria?
Then child has also microcephaly.
Okay, very good. One.
And the nutrition of the child also, the child appears to be less than 2 standard deviation, not less than, as in BMI appears to be less.
Okay, great. Though history is not that in between child is as per mother is okay, but if you look at the anthropometry measures, it doesn't appear that child was okay in between. So it is again an evidence that it is a progressive disease. Third, any other? Any other point which will be pinpointing that probably it is metabolic and likely there is a mitochondrial disorder. Recurrent episodes, remember?
It's
Yeah.
mostly associated with fever. Like last time also she had a fever, and this time also with the fever.
And weakness, whichever it is. Though we are saying alternate weakness or weakness on the same side, recurrent type. So probably it will suggest that there is a same pathology is involved. So that's why that point is also in favor of probability of mitochondrial or metabolic input. We have to consider. Okay.
Yes.
So any other differential diagnosis would like to keep? Last one more. Why not? It is some genetic disorders because it is having a microcephaly, having weakness, right? Some.
Yes, sir.
Is there any anomalies, external anomalies? Did you look in the physical examination? Did you see that one?
No, sir. There were no other external anomalies. Only the microcephaly.
Yeah. If there is any external anomalies, then you have to consider there might be a internal anomalies also. So probably it will be more like some other genetic disorder. So some congenital anomalies presenting with this picture. Okay, that also you should consider. Okay, right. So your final diagnosis is?
So basically, with global aphasia, with left hemisphere with status epilepticus, most likely due for hello.
Hello. Yeah. There is some in between break.
Sir, I'll just repeat again.
Okay.
Microcephaly with global aphasia with left hemiparesis with status epilepticus, most likely due to a cortical thrombotic stroke, which could be secondary to some meningoencephalitis, viral meningoencephalitis, or could be metabolic, or could be due to hypocoagulable state, most probably in the right MCA territory.
Okay. Okay. So how do you now approach these children? So what investigation, most important relevant investigations you will do to confirm your diagnosis?
Sir, CT sir would be required.
So straight you want to go for CT, you are neurologist.
No, sir, before that, the routine investigation, sir, you like to know a blood routine to see for the total counts.
Okay, very
So
good.
any elevated total counts, any neutrophilic or lymphocytic predominance.
Okay.
Platelet count we would like to see, sir.
Very good.
Then the PT-INR will be required, sir. For any
Okay.
bleeding. Then lipid profile, sir.
Why lipid profile?
Sir, presented with the thrombosis, like.
They are all secondary. Okay.
Then peripheral smear for sickle cell.
Most important is peripheral smear. Okay. In the hemogram, the peripheral smear will give a lot of clues for you, even though it is a neurological condition, but still you will get. Yeah. Okay.
Then lumbar puncture, sir.
Yeah. First, before you go for lumbar puncture, what you have to do? So you have sent investigations hemogram and waiting for the report. But meanwhile, what you will do before you go for LP? Huh?
The
fundus examination. Yeah, fundus examination. So what is there in the fundus examination? Did you do the fundus examination for this child?
No, sir, I didn't.
Why? It is most important. Bedside investigation. Every postgraduate has to do that one. You should always carry the ophthalmoscope. It is one condition. You don't wait for ophthalmologist to come and examine and then say that there is a raised ICT features. No, you have to do that one. So it is no exception for this. Every postgraduate has to this. It's a bedside test. Okay, like any other clinical examination, this has to be done. Okay.
Yes, sir.
Okay. So if there are signs of raised ICT on fundus examination, so would you like to do LP for this child, or you want to go for other tests?
So we would avoid an LP in this channel.
You would like to
So
avoid?
we would not. Yes.
Why?
It can cause a herniation in raised ICT.
You are in the periphery. Of course, you are in Goa. You have a facility for doing imaging studies, but unfortunately, your imaging was not done because of certain technical problems. So what you will do now? No imaging was done for next 12 hours, 24 hours. What you will do? You will still defer your LP, or you will go ahead with the LP? Yeah, one of your friend has messaged.
Guarded LP, sir.
What is that guarded LP? No. Okay, what you can do is in a dire situation. Yes, definitely if there are raised ICT, first you should always do a imaging study, and then you can go with the LP. If not, then what you have to do is give mannitol. Okay, and immediately within half an hour you can do a LP, provided take all the necessary precaution, and most importantly take consent from the parents, and then go ahead with the LP. Okay, that is what is guarded LP. You have to explain, take consent, explain to the parents, and then go ahead with the LP. Okay, you did LP. So what findings you have find?
So the LP which was done was normal, sir.
Okay, fine. So there is no, what do you expect in viral CSF? You are saying first possibility is viral encephalitis.
RBCs in the
Very good.
and lymphocytic predominance.
Okay, RBC, in which virus you will get RBC? Of course, if it is not traumatic, in traumatic you will get various. Okay.
Yes.
In which virus you will get RBC in CSF? Not all viruses will have this.
HSV, sir.
HSV, common, not HSV. Where else you can get? RBC. You said enterovirus. Which enterovirus?
Yes. 71, sir.
Yeah, 71 and Coxsackie. Okay. Then you will get that RBC with this. Okay. Right. So protein, is there any pleocytosis? What is pleocytosis?
Pleocytosis is so the cytoalbuminoid dissociation.
Dissociation. So what exactly you will see?
So the proteins. Proteins are more compared to cells, sir.
Okay, there is a disproportion between cells, what you see number of cells, and the amount of protein in the CSF. Okay, typically there is a dissociation. In which condition you will get?
Pardon, sir?
In which condition you will get typical dissociation in CSF?
GB syndrome. GB syndrome, sir.
GB syndrome. Serial examination, not one. Serial examination will give you. Okay, that is okay. You did CSF. Next. So make sure that you need to send for viral culture all these CSF samples, including your JE. Okay. Next. What else you will do? Imaging study.
Imaging studies, sir.
Okay.
Non-contrast.
So you have both in your hospital, MRI and CT. Which one you would like to do for this child?
Actually, sir, MRI would be a better modality
Why?
for the to look out for the areas of infarct.
Remember, for not always MRI is good. Only depending on etiology, you need to consider. Now, if you are considering a congenital anomaly or hemorrhage, it is always preferred and better is CT scan. Quickly you can get it. Okay. In other modes, yes, definitely you need to
The
consider
viral
it.
etiology.
Which one?
So for viral etiology, it will be a better modality.
Yeah, definitely parenchymal involvement. That's what I said. For CT, if there is a hemorrhage you want to consider or anomalies you want to consider, go for CT scan. Otherwise, rest of them definitely need to consider MRI. Okay, right. So, any other investigation you would like to consider here in this child? Now, based on your MRI findings, later you can consider other. If you think the other possibility other than viral, like hypercoagulable is thought, or the second one you considered was metabolic. Huh? So then you need to send those investigation accordingly. Okay.
Yes.
Now, did you have any investigation for this child? Quickly, you can mention if you have done already.
So CT was done, sir.
Okay, good.
Yeah.
Why not MRI? You said better prefer for viral MRI, but why you have done CT? No, not able to hear.
Yes, sir.
No, not able to.
The child was intubated that time.
Okay, so it was intubated. That's why you didn't do MRI. Okay, now you want to do again MRI for this child. Now he's off ventilator, off oxygen.
Yes, sir.
Okay, if you do MRI, what do you find? If you are thinking it is metabolic, probably may last. What findings you will see in the MRI? No? Difficult. Okay, I think we have now at least made an attempt to come to proper diagnosis, near to the proper diagnosis. Okay, any child presenting with fever, altered sensorium convulsion, first possibility always these acute febrile encephalopathy you need to consider and work up for those cases, right? So, and now you have made that probably it is either viral encephalitis causing all these sequelae, or it is probably still under workup for metabolic conditions. Okay. Right. Anything, any questions you would like to ask? All postgraduates, any questions related to this case you would like to ask? Is there any deviation from what we have discussed so far? Yeah, I'm not able to hear. Dr. Sonali? Hello? Madam, we are not able to hear properly. Hello?
Hello. Hello.
Yes, madam. Now we are able to hear.
Hello?
Hello. Yes, madam. We are able to hear that.
Yes. Okay.
Maybe internet.
Hello?
Hello. Yes, madam. Now able to hear.
Yes, yes, you can hear. Yeah, I think there was some connection. Yeah, I think there was some connection issue.
Yes, madam. Yes, madam.
Yeah. So thank you very much for an interesting discussion. Thank you very much, sir.
Thank you,
On
madam.
behalf of
Thank
the whole
you.
department. Thank you, sir.
Thank you. Thank you. Thank you very
Thank
much.
you, sir.
Okay, madam. Thank you. Thank you, one and all postgraduates.
Thank you, sir.
Thank you, sir.
Okay, thank you. So can I take leave, ma'am? Okay. Thank you.
Yes, sir. Thank you,
Thank
sir.
you. Thank you.